Hello, everybody. Thank you for joining Khanversations. Today, I'm with a young and dynamic doctor, Dr. Ashwin Karnik, who is talking to us from the state of Washington, the epicenter of where all of this began, at least for the United States. The coronavirus pandemic started in the state of Washington, and he is a freshly minted doctor. So congratulations, Ashwin, on completing your medical studies. He is a first-year intern in internal medicine at the University of Washington, which he will complete in a few months and start his internship or his residency in psychiatry. So Ashwin, thank you for joining us. And I must start off by saying that there is no words with which we can thank our medical professionals who are literally on the battlefront right now, risking their lives every day to contain this pandemic, and especially people like you who are beginning their careers in medicine with perhaps one of the most dreadful pandemic that we have witnessed in a long time. So tell us, how is life in the ER where you are right now, and what's going on?
Certainly. First of all, thanks for having me on one of these conversations. I feel like it's a really useful series to have to gather all these important perspectives together. And so I'm super happy to share mine. Right now, being in the emergency room is not what I expected it to be like. So before this all began, we prepared for the worst. We prepared for more patients to come in than we would normally be able to handle. We prepared for lots of really sick patients. We prepared for the possibility of having to crowd patients into rooms and cram them in the hallways, and just kind of like a touch and go sort of care in the ED. But honestly, we prepared so well, and now it's actually very quiet in the emergency room. I think it's kind of been a couple of phases. So our hospital that I'm currently working at right now, it's very used to having a super high volume of patients because we are the only level 4 trauma hospital for 5 states in this area. But with the governor of Washington, he was very on Jay Inslee. He was very on top of sort of these shelter in place recommendations, try to minimize contact with people, that kind of stuff. And I think overall we have a very collaborative culture in Seattle comparatively to a lot of other large cities. That people really followed those recommendations, and we're not seeing a whole bunch of people showing up to the hospital, showing up to the ER. We still are seeing cases of patients who are testing positive for COVID, and I'm testing so many of them every day, and maybe a couple are positive each day. But we've really, I think, with these shelter-in-place recommendations, we're starting to achieve this flattening of the curve here in Seattle, which I know is not exactly the case in some other big cities that are struggling a little more than we are. And so it's not like what you see on TV in the popular TV shows right now. It's not like masses of people coming in seeming like a disaster. It's actually fairly well controlled at this point. It definitely was choppy at first. There was a while where we didn't really know what we were doing as a hospital, because this isn't something unfortunately we just weren't prepared as a country, as states, as individual hospitals. We were not prepared for this.
So do you remember when you went from being, oh, we are not prepared for this, to the point where, okay, now we can handle this, right?
Yeah. It's been interesting for me. So every month we're on a different rotation. The month of April, I happen to be in the medical emergency room. The month before this, in March, when we were really realizing okay, we need to start making policies to address the pandemic in our hospitals, I was on an inpatient medicine month where I was the only resident, and it was a bunch of attending physicians that I was working with. So I was sharing the same workroom with them, and at that time, these were also all the physicians who were meeting every day to try to decide the best policies. So they kind of unofficially included me in these discussions, and these discussions happen multiple times a day. They got like the perspective of residents from me. And with these discussions happening multiple times a day, we really didn't know what we were doing until we had to just try doing it. So our approach was to like diagnosing people, to isolating patients in rooms. Our approach to all of those little details was changing every single day. And March honestly felt like the longest month of residency because of that. Just the stress of having to, of the uncertainty of, how are we going to deal with this? And are we even doing this right? But come April, especially like the first week of April, when our projected peak was, I think our peak was projected to be like sometime between April 2nd and April 7th. And we didn't exactly have the peak we were expecting, which was good. I think we gained a lot more confidence. And protocols are still changing a little bit here and there every single day, but for the most part, we've kind of got a flow down now. We've got a rhythm, and that's especially important in the ED, where sort of that initial triaging is happening. And so being in the ED now, I kind of see where the confidence is sort of needs to be and where it is now. So I feel
So that's
I
very
feel
interesting. I want to let my audience also know that you have some academic instincts. You have also written a book chapter in a book on how physical exercise, etc., can improve the health condition of human beings. So maybe your informal participation in the policy making could be the making of the next book, how to handle and how to prepare for pandemics and emergencies. Listening to you, it is coming as a bit of a surprise to me as to why the rest of the country is not using the state of Washington as kind of a model to prepare and challenge it. Like, for example, I think Delaware is going to experience its peak in this coming weeks, this week or the next week. And we realized that yesterday we had a huge spike in the number of cases that were detected. And the Northeast, basically New Jersey, New York, are experiencing a lot of cases and a lot of deaths. When people were coming in and having these tests, did you conduct any of those tests for COVID? And can you tell us something about how those tests are conducted?
Yeah, certainly. So when a patient comes into the ER with some respiratory symptoms, um, we do a nasal swab. And so for me, I don't actually physically conduct that swab myself. It's the nurses doing that. So they're really, um, I feel like the heroes who deserve the applause, spending the most face-to-face time with these patients. But as the physicians, we're also having to see the patients up front. So I see the patient, I say, okay, I think this person either has a high likelihood of having COVID, or maybe even a low likelihood of having COVID, but our threshold to actually test people is very low now, because at our university, we have our own lab where we developed our own test. So we can do a lot of them. So I basically I put the order in the computer,
Mhm.
but really the nurse does the swab. It's a very, very uncomfortable swab, I have to say. I had to be swabbed because I was sick about a month ago, and we just didn't really know, like, oh, our healthcare workers getting affected by this at a high rate. We should probably test everyone that gets sick just to see what's going on with those numbers. Um, it's a very, very uncomfortable swab, but we are swabbing so many people every single day. And there are people who we don't think are going to have the illness. We just want to rule it out. But surprisingly, their test comes back positive. Or there are people who, their history of their symptoms is very suspicious for the illness. We do some other labs or imaging, and it's like, oh, it looks like this person has a viral pneumonia. We better test them. And they test negative. And that can be for a variety of reasons. The test is not perfect. There's still like a 70% like true positive rate, meaning out of 100 people who have the disease, who get the test, maybe only 70% of them will actually have a positive test and 30% will have a negative. So there's still some imperfections in how we're testing.
So
But at this
basically,
point,
you let them go back into the wild, so to speak, and they may have COVID, and you don't know that, right?
yeah, and the advice we're giving people now, and this sort of is very specific to our university because the tests we've developed, we have two tests right now. One that is sort of like a slower, a little bit more accurate test that takes maybe 5 or 6 hours to come back, and then
Yeah.
the other one is a very rapid test for certain situations that comes back in really 1 or 2 hours. So first of all, we're extremely lucky to have these very fast turnover tests. But usually what we do is if someone's not sick enough to have to be admitted to the hospital, we'll do the test for them. We'll say, okay, go home, isolate yourself if you can, and we'll call you if the test is positive. Um, and honestly, at this point, there are a lot of people coming to the emergency department, once every couple weeks for something. And we look back in their chart, and maybe 2 weeks ago they were tested. Um, and it was negative, but they're back with like new respiratory symptoms, and we test them again, and this time they're positive. And it's hard to say, were they positive this whole time, or was the first time something else, and now this is COVID? It's very hard to say, but the
Do you
experience in the ED now has been that we're wanting to really increase the number of tests we're doing.
there is a lot of talk that there's going to be a kind of a second round of infections that are going to come. And the fear is that the virus may adapt, and the second round will be much more difficult virus to kill and to treat. And are you hearing some talk about it or preparing for it in some way at the hospital, or just
Yeah.
dealing with the crisis now?
So I'm hearing a little bit of talk about it, and really mostly from my non healthcare friends, because to be perfectly honest, with the rotation that I'm on right now, with the work that I have to do now, I'm basically just focusing on going to work, doing the job that I have to do, and coming home and not trying not to think about this all too much because it's very overwhelming.
Ah,
Um,
share
to,
with
to
us
think about.
share with us some of your own psychological, I mean, I don't want to don't want you to diagnose yourself, but like share with us how do you feel about this whole experience of going every day to the hospital, knowing that that it's a dangerous place to be. I'm afraid to go shop for milk, but you are going there every day. How does it feel?
Honestly, it's a big weird mix of feelings. First of all, I feel proud that I get to help, like I get to be on the front lines. It's an unparalleled feeling, I think, in healthcare. I feel all the time in healthcare that I'm doing something important, but at this time, it feels like something way bigger than what I ever imagined, a way bigger purpose. I feel really frustrated with our system, our broken systems that have led us to this point where our national response is so poor. Um, I feel angry with people who are maybe not taking this as seriously as they should. I'm nervous. As you said, as you implied, there's maybe going to be a kind of a second wave, and whether that's because the virus has some sort of genetic alteration that it undergoes, or um, we start to get a little bit more lackadaisical about our precautions as a community, and the spread just goes uncontrolled again. So I'm nervous about that, but I mean, overall, I also just feel really thankful, like really grateful that I get to learn with this like very unprecedented, sort of unparalleled learning experience that residents. It's a once in a lifetime. I hate to call it an opportunity, to be honest, because it's really it's a tragedy.
Yes.
Um, but the kind of wisdom to be gained from this, to hopefully make the world a better place tomorrow, is really rare.
You,
Um,
you, you know, I want to also focus on this aspect. I understand that you are too busy to look at the broader picture and the national picture, but one of the things that is coming out is that the virus is as discriminatory as our own socio-political system is. So for example, people who are marginalized, people who are poorer, people who do not have proper access to healthcare, and not even proper access to information about what precautions to take. Instead of listening to doctors, they're probably listening to conspiracy theorists, etc. So given this huge inequity in the system, if you look at Louisiana state, for example, 70% of those who are affected there are African Americans. In Chicago, 40% of those who are dying after infection are African Americans. So we see that a particular marginalized racial group or people who are from the poorer background are disproportionately being affected and are dying as a result of this. Now, Seattle, I mean, Washington is not as diverse a state as other places, but are you actually witnessing this in your hospital and in your clinic?
Yeah, yeah. Unfortunately, we are, and we expected that as well. Um, and there are examples of like ethnic minority groups that are being affected more. We have very large populations of Somali people, Ethiopian people, that I think I don't know the actual numbers, to be honest, of the
Sure.
data. But what I'm seeing in terms of the patients coming through the emergency department, I am seeing these ethnic minorities coming in for testing and testing positive more often than I'm seeing non-minorities. And I think that one of the biggest minority groups that is like this disparity is so apparent here in Seattle is the homeless community. We, I just, I think a lot of people don't realize that sheltering in place is a privilege. Um, in order to shelter in place, you have to be housed. Your home has to have enough space. You have to have enough of your own space, meaning if you live with a lot of people or if you share a room with someone, it's not really possible. Um, and so many other things. And so when we started to see the overall rate of positives sort of leveling off here in Seattle, we kind of took the homeless population specifically and measured their rate, and really their rate of positives tests was increasing. Unfortunately, we have several shelters here in Seattle and in the surrounding area, and unfortunately, there have been a few outbreaks at these shelters. And when someone who is not housed or who is at a shelter comes to our emergency department to be tested for this, if they test positive, they cannot go back to their shelter, unfortunately, for a period of time. And so then they lose their shelter bed, and then we have to, we don't, our hospital has really tried to kind of set up a part of one of our buildings for these people to stay and live in the meantime to help them self-quarantine, but it's not perfect. And you can't give them everything they need to really thrive every day. And so these are the people who are suffering the most, I think, in Seattle specifically.
It is also possible that they don't have access to information, right? Like they're not watching TV, they probably do not have Wi-Fi, and so they probably do not know what measures they ought to be taking in order to cope with this pandemic and all the, I mean, the rules are also changing, as we move around, especially with on social distancing issues. Uh, I also want to talk to you about, I mean, this is clearly a case of where income inequality is one of the drivers. And you will see this across, I think, other diseases also, that the poor are, because they eat unhealthy food and perhaps they don't have access to gyms and healthcare, are definitely suffering more. But do you also feel that other marginalized communities like religious communities or LGBTQ communities who are also suffering more than others as a result of this particular pandemic?
Yeah. Um, I think there are minority communities that we don't necessarily automatically associate a certain like socioeconomic disparity with, maybe we do, that are suffering most likely because of the socioeconomic disparities that come with being part of this minority group. I would say, I mean, you mentioned that the LGBTQ community specifically as one example, and this is a community that, at least in Seattle, and I'm sure everywhere else, has higher rates of psychiatric issues, higher rates of homelessness, and other medical comorbidities than the general population. And I think for that reason, we might be seeing different outcomes for those folks. But I'll be honest, I don't really know the data. Um,
I checked on the data. It's very interesting. So, for example, about 25% of the LGBTQ community works in two industries which are directly impacted, which is medical and health professionals and restaurant. And so one aspect of it is completely hurt business-wise, which means they probably lost their jobs, they lost their income. And then the others who are clearly exposed to the chances of getting COVID-19 because they are health professionals. I also discovered some odd things, like, for example, 37% of LGBTQ community are smokers, 17% are poor, and among those who are transgender, the poverty rates are way above national. So because they're poor, then they have the same problems approximating what the homeless probably have, right? Are hospitals becoming sensitive to these challenges, that people may suffer as a result of this? They may not be even willing to come and get tested, etc. Are our hospitals being good citizens in that sense?
yeah, we're definitely thinking about those things. Like maybe the people who are actually suffering from this virus or getting this virus actually have less access, so they're less likely to come and get tested. So is there a way to reach out? Um, we have some amazing, brilliant people here in Seattle who are really trying to work on outreach, healthcare outreach for those very vulnerable populations
Mm-hmm.
that just don't have good access to healthcare. Um, and I can't give you any specific examples off the top of my head, but I have some co-residents who are trying to champion some projects. I don't know, I'm not currently aware of if there are like hospital associated policies to try to reach out or do community-based events like that, to really try to highlight those communities and get them plugged in more. But Seattle, I can definitely say that Seattle is a city where there are enough people who want to do that badly enough that they're actually starting to do that. And
I mean,
pretty,
Seattle is also at the forefront. Bill Gates is, I guess, still based in Seattle, and he is not only putting his mouth, but his also money where his mouth is on this particular issue, donating money for research and all of these things. Yesterday, I interviewed a psychiatrist who's been practicing for several years, and she made a very interesting point that it hadn't occurred to me. She said that one of the things that preceded, I was talking about pre-existing scenarios before coronavirus, such as mental health crisis, high suicide rates, opioid addiction, abuse, etc., which already existed before coronavirus. And now coronavirus is going to have some kind of a multiplier effect and exacerbate all those crises that we are facing. But she also said that there is also this situation of physician burnout. So not only physicians are overly stressed, but they are also experiencing this burnout. On top of that, when we talk about mental health crisis or even abuse of substance abuse, we do not talk about its impact on the medical profession. I mean, are you seeing doctors and others? I mean, I don't want you to rat out anybody, but do you think that broadly speaking that the stress levels are higher and mental health concerns are therefore higher?
yeah, absolutely. And So in terms of healthcare professionals and physicians in particular, um, I can I can even just say from my own experience that yes, the stress levels are higher and the burden on our mental health is higher. I am someone who needs to like regularly check in with my mental health in times of stress, and even just periodically. And so I've had to do that for myself through this pandemic, mostly because where the stress is coming from, at least for me and a lot of my co-residents, is having to think about this pandemic like 24/7. Like there's nothing else we can really spend time on at this time. We live, work, and breathe the pandemic at this moment. Um, and the fact that we just don't get a mental break to think about anything else is tough. It is getting a little bit easier as our response is going on and the curve is flattening. But really, in terms of just having to think about nothing else other than um, coronavirus, it's that's really where a lot of the stress is coming. I will say, I personally have not been in the more busy like medical units, like the intensive care unit. Um, I've not been. We have one hospital in particular that has a lot of COVID positive patients, and so their burden is very high in terms of patient care. Um, and in talking to some of those physicians, they feel physically tired as well, having to put on all of this protective equipment, going into a room with a very sick patient, putting themselves at risk. Um, Anesthesiologists having to intubate these patients. And there are a lot of physicians who have decided to move out of their homes because they don't want to expose their family. Because, truth be told, as good as we are at the hospitals at our precautions, we are probably the chances of us bringing home the virus on something we're wearing or something we're carrying is pretty high. So people being more isolated is also weighing on their mental health, and having this uptick in our workload. I'm afraid may break it may be the straw that like breaks the camel's back for someone at some point. We are really trying hard to support each other. Our institution is trying to support all of its staff, and I think so far, at least here in Seattle, we're okay. I know the story's not the same in a place like New York. Um, I've heard from some of my friends who are residents in New York that really things are not okay there. Um,
You know, one of my cousins is a psychiatrist who treats substance abuse. And I asked him once, I remember a couple of years ago, so are there a lot of people from our community that you deal with, that you treat with? And so basically, I wanted to know if there are lots of South Asians or lots of Muslims who are constantly getting affected by drug and especially alcohol abuse. So I was just curious about it. So he was quiet for a second, and I thought that maybe he was hesitant to share the numbers. He said, actually, I deal more with people from my community. And then I looked at him and said, what do you mean? He said, I treat for substance abuse those who treat people suffering from substance abuse. And so he was basically talking about doctors whose job is it to deal with substance abuse who are themselves abusing. And I was kind of horrified. I said, they know everything about it, but why? He said, it's the stress. It's the stress of the profession. It is also sometimes the inability to get the work and life balance together, right? So in pandemics and exercise like that, I think for a lot of us, the work and life balance has been completely upset. So I know you're very young and at this time, but I also have lots of students who are roughly around at this point. They're finishing their colleges and about to enter the workforce, and there's so much uncertainty about the economy and the work. Is there anything that you can say to my students and to younger people, your cohort, that is positive to look forward to, or something that they should be careful and alert about?
yeah, I'll say that people graduating, people entering the workforce with young, fresh minds. Um, Now is the time to apply what you've learned and maybe even keep trying to learn things that you would have expected to learn, but can't because the economy is the way it is, and maybe you won't have a job immediately. Keep trying to apply yourself, because that's really the only way that we can sort of retain the hope that we need in order to get through this. And we will get through this. It's just, what are we going to look like and feel like on the other side? That's important. And I think finding a way to finding a way to feel like you matter, which everyone matters, whether or not they're working right now. Everyone matters in this, but really finding ways to feel like you are you, feel like you can live the life that you wanted to before this all happened, which is easier said than done for people maybe who have privilege versus people who don't have a lot of privilege, in many ways. But I just think we're going to rely on the people who are still very hopeful, still young and fresh, after this, because when this is over, there's going to be a lot of jaded people. The economy is going to be hurting. The healthcare system is going to be hurting. Healthcare providers are going to be burnt out, understandably.
You know,
And
I
yeah.
was I was reading some statistics about England, not so much about the U.S. I have not seen any such uh, studies about the U.S. yet, but a disproportionate number of people who serve in the medical profession in UK who are on the front line are essentially immigrants, especially from South Asia. Lots of doctors and lots of nurses, and many of them have actually died. In fact, I know some people who are not exactly like regular close friends, but people I knew who have lost their lives as a result of combating the COVID pandemic and then getting infected themselves and dying. So it's quite possible that that we might see a similar, as the economy declines, another backlash against immigrants, etc. Are you already sensing that? Are you seeing any evidence that people are not happy that when the doctor that they are facing is not white?
Yeah. I face that all the time. And at this time, there might be patients who don't usually come to the hospital but are coming now because they're scared that they might have the virus. And these are people who don't have a lot of run-ins with the healthcare system for whatever reason. Either that they have a lot of fear of the healthcare system, they have a lot of they're unfortunately ignorant of they just don't have a lot of healthcare or health literacy, and often these are also people who are more likely to have a lot of other biases, like racial bias.
What do you mean by health literacy?
Oh, so what I'll say about health literacy, it's sort of just a basic understanding of um, how to think about one's own personal health, and how to receive and process education and information about health. So, for example, I think there are a lot of people who are proving that they don't have a lot of healthcare literacy during this pandemic. People who say like, "Oh, I don't really care. Um, like I'm probably if I get infected, like I'll probably be fine." And so they want to be out in crowds, have parties, get together with friends, putting other people at risk. When the reality is everyone's at risk. Young people are getting this and dying from it. Young healthy people. So that's like an example of poor health literacy during this pandemic. But also health literacy just has to do with like understanding how to take medications, when to like ask your doctor more questions, or when to come back to the hospital, to the emergency room if you think something's not right. Um, Things like that. And it's on us, it's on healthcare providers to provide that health literacy. But at the same time, we can't do all of that education. There are populations that just don't encounter the healthcare system very often, and in fact, they just don't encounter people or a diversity of community very often. And so, when you bring up the point of people having these like biases against immigrant communities, like that's sort of where that comes from. Um, like a white blonde nurse is going to likely provide the same exact care as like a Filipino nurse. An Indian doctor is going to probably provide just as good care as a white doctor. Um, but people don't understand. Some people who just aren't exposed to diversity a lot just don't understand that. It's important to have a lot of patience with those people, especially at a time like this where the stakes are really, really high for us to try to have a good sort of therapeutic relationship with our
I mean,
patients.
it's putting more demand on the doctors, right? Not only to be able to be good at just dealing with a particular ailment, etc., but also being good at personal relations, interpersonal relations under adversity. You know, Dr. Karnik, Dr. Ashwin Karnik, you have no idea how much pleasure I get by saying that. When I came to the United States in 1992, you were a baby. You could neither walk not talk. And I've watched you grow up, and I'm very proud to see that now you are a doctor. For those of you who probably guess, Ashwin is my nephew, and I'm very proud of him. And I also pray for you every day that you be safe. And it's amazing that so early in your life you've been thrown into the deep end of life, really, in facing those challenges. And for those of you who wonder how doctors really deal with stress and how they de-stress themselves, here is your moment of Zen.